Welcome again. We're going to talk about the acyanotic heart disease, starting with the atrial septal defect. As we said before, the incidence of atrial septal defect is 6 to 8%. That is in some studies, but others say it is up to 10%. And we have to understand that not all studies give the same numbers exactly. It is 2 times more common in females than in males. The age of presentation varies as it is affected by the size of the defect. Small defects are not seen, or maybe they are closed early in life. Maybe they can persist later on. Moderate defects can present in the second decade of life, but larger defects are the ones that present early in life. Types of ASDs include the ostium secundum, which is the most common type, the ostium primum, and the sinus venosus. The ostium secundum is a defect in the fossa ovalis, in the middle part of the interatrial septum, and in ASD, the blood flows from the left atrium to the right atrium, and then to the right ventricle, and there is increased flow across the pulmonary artery. And this means that there is an increased load of blood over the right side of the heart. In ostium primum, it's an interatrial communication between the bottom end of the atrial septum, the lower part, that's it, and then there is a defect in the mitral leaflet. Cleft mitral leaflet يعني مشقوقة المitral leaflet, this can cause mitral regurg. There is also an abnormal atrioventricular junction and abnormal AV valves. The sinus venosus defect is a defect in the upper part of the interatrial septum, close to the superior vena cava and the pulmonary veins, and frequently there are abnormalities in the pulmonary venous drainage. That's a difficult defect to diagnose. The clinical features of ASD vary according to age and the size of the defect. The patient might be having no symptoms, and that is common, particularly in small defects. The defects might close spontaneously early in life, or the patient might come and say that they have the child is not growing normally. Growth failure يعني الأم تيجي تقول الولد ده ما بيكبرش يعني ولا البنت دي ما بتكبرش مش بتاكل حلو ما بتكبرش كويس. Mild dyspnea and fatigue. They don't always say that there is dyspnea. ويقولوا الطفل ده ما بيلعبش زي بقية الولاد يلعب شوية بعدين يتعب. Recurrent chest infection. We have to ask about it. أم تقول إحنا الشتاء ده الولد ده جاله التهاب رئوي مرة و3 مرات جاله التهاب في صدره ودخلنا المستشفى كذا وأخدنا علاج محتاج حقن لمدة قد إيه. This is due to increased pulmonary circulation, increased pulmonary blood flow, frequently associated with wheezing. Patients might be having larger defects with symptoms of heart failure. Heart failure في الأطفال infants, and in neonates it presents with difficulty in feeding, and they are having dyspnea, or they cannot respire normally during feeding, and they are tachypnic with excessive sweating, and we're going to talk about heart failure later. Cyanosis on effort. الطفل يكون مزرق بس the later on in life. It does not usually occur in children, but it might in large defects. Arrhythmias at an older age. On cardiac examination ASD, we look at, first we inspect. We look at the mitral area, tricuspid, third and fourth space, pulmonary area, the infraclavicular area, and the aortic area. And we find that we look for a precordial bulge. Precordium is the area overlying the heart. It is not the pericardium. It is not the membrane around the heart. We cannot see the membrane around the heart with our naked eyes, but it is called precordium, the area above the heart. If there is a large defect that is present from early infancy, there might be a precordial bulge, but it is not common to have a precordial bulge in small defects. And it is a calm precordium. There are no pulsations or excessive pulsations. We auscultate for the first and second heart sounds. Normally, the first heart sound is formed by the mitral and the tricuspid closure, valve closure, and the second heart sound is formed by the closure of the pulmonary and the aortic valves and heard better at the pulmonary area. The first heart sound is heard at the mitral area, so the patient, it goes like that: lap tap, lap tap, lap tap. But since the second sound is formed by two components, the aortic and the pulmonary, sometimes we can hear the second heart sound as narrowly split or physiological splitting of the second heart sound. Lap trap, lap trap, lap trap. But in ASD, the second heart sound is splitted. There is more space between it and the aortic component, the pulmonary aortic component, and this is due to increased flow across the pulmonary artery, so the pulmonary valve closes later than the aortic valve, and that is what we hear: lap trap, lap trap, lap trap. The murmurs heard are an ejection systolic murmur heard maximally on the pulmonary area, and there is the fixed splitting of the second heart sound, and we explained why, and there's a flow murmur, diastolic flow murmur. So let us hear the heart sounds here. Normal heart sounds, these are the normal heart sounds, the first and second heart sound. The second heart sound might be splitted. As you can see, a splitted, fixed splitting of the second heart sound. Please use your headphones to hear the heart sounds. So we're going to revise again. What do we hear in the ASD? We hear on the pulmonary area a fixed, widely split second heart sound, an injection systolic murmur on the second left intercostal space due to increased flow across the right ventricular outflow tract. What is a right ventricular outflow tract? It is the area under the pulmonary area where the pulmonary valve and the pulmonary artery where the right ventricle is giving the arise of the pulmonary artery. And here again, you can hear the fixed splitting of the second heart sound. And on the tricuspid area, you can hear a rumbling mid-diastolic murmur due to increased diastolic flow across the tricuspid valve, but it is a grade 1/6, and it is not a loud murmur. It is grade 1/6. The X-rays of all the shunt lesions actually look like one another. There is increased cardiothoracic ratio, and you're going to see cases of X-rays and radiology later on. There is an enlarged heart, increased cardiothoracic ratio, increased prominent pulmonary artery. This is the site of the pulmonary artery, prominent pulmonary arteries, and increased bronchovascular markings, as you see here. The ECG. We have to understand that the ECG varies with age. So there are age-related changes from birth till adulthood. The baby is born with a predominant right ventricle, but due to changes in the ratio of the left ventricle to the right ventricle, these appear with time. The normal right ventricular dominance of the newborn period is gradually replaced by the left ventricular dominance of late childhood and adulthood. Let us quickly revise the waves and the intervals of the ECG. This is the P wave. This is the Q. This is downward deflection. This is the Q. R is a positive deflection. And S is a negative deflection. And that's the T wave. And these are the intervals, the PR interval, the QRS, and the QT intervals. And when we do an ECG, we do what is called standardization. We have to have, we have to have two large squares. We find two large squares drawn before the ECG tracing to know that this is the standardization of the ECG. This is a normal ECG of 2 months, and in it we can find that there is a right ventricular dominance because this is normal for that age. Okay. Normal ECG for a 5-year-old, we find that the left ventricle started to appear, and it is not anymore the right ventricle that's taking the upper hand. So we're not going to discuss the ECGs today. It is just to say what is the abnormality that I find in the ASD. The ECG in the ASD shows that there is a sinus rhythm that means that the wave is coming from the SA node. There is a right axis deviation and what is called partial or complete right bundle branch block, and we're going to see this in the ECG later on. And in the Ostium Primum we find a left axis deviation. And this is what is called the RSR dash. We know that R is a positive deflection, goes up and then goes down, the S, and another positive deflection is the S, the R dash in V1, indicating right axis deviation and right bundle branch block. So this is an ECG from a 4-year-old girl with ostium secundum showing an incomplete right bundle branch block RSR dash pattern in leads V4, R, V1, and V2. Here it is, RSR dash pattern. The echo. There are two ways of performing an echo. The transthoracic echo, that means we are holding the probe over the chest of the patient. And in this echo, look, it is lovely, you see the chambers of the heart. Look here, we have the left atrium, the right ventricle, and the left ventricle. And there is a defect in the lower part of the interatrial septum, and this is called the Ostium Primum. So we have to look in this patient for a cleft in the mitral leaflet and the AV junction, the abnormality. Sometimes we can do what is called a transesophageal echo, not a transthoracic, in which the patient swallows the probe in the esophagus and we look at the heart from the esophagus. And in this patient we find a huge right atrium because there's a large ASD, and we can say it's an ostium secundum because there is a small part present here. Okay. And this is the left atrium and blood flows from here to here, and that is why it is making the right atrium bigger in size. What are the complications that we face in ASD? Sometimes it might close spontaneously early in life and the patient is lucky, but the patient might develop pulmonary hypertension and pulmonary vascular disease, and this is late in life. It is not that common in children, but we have to understand that pulmonary hypertension is a very grave complication in all the shunt lesions, and we have to operate on our patient before developing pulmonary hypertension. We follow our patients closely to avoid the occurrence of pulmonary hypertension. The patient might be presenting with heart failure or might present with pulmonary emboli. Why pulmonary emboli? If the patient is having thrombosis in the pelvis or deep venous thrombosis, the thrombus will travel here in the inferior vena cava, comes to the right atrium, comes to the right ventricle, and then goes to the pulmonary artery to reach the lungs, causing pulmonary emboli. But sometimes what is called paradoxical emboli can occur. The patient, if he strains, if he's coughing, crying, so the embolus present here in the right atrium might travel into the left atrium, goes to the left ventricle, and then goes to the aorta. And in the aorta, it can reach the whole body from the aorta, goes to the brain, goes to the spleen, goes to the kidney, leading to paradoxical emboli. These paradoxical emboli might be infected and cause brain abscess. Patients might develop arrhythmias as atrial fibrillation and atrial flutter later on in life. How am I going to treat an atrial septal defect? You have to measure the graft parameters and treat graft failure with proper feeding of the infant or child. Treat chest infection and heart failure. It is important to control the heart failure if you want to have your baby growing normally. and you have to treat chest infection, maybe vaccinate the child, because the repeated chest infection actually leads to more heart failure and the patient deteriorates with each chest infection. Symptomatic infants and infants with evidence of right-sided volume overload should be offered surgical closure or closure by catheter device. So right-sided volume overload is an indication of intervention. Surgery is usually electively done at 4 to 5 years to prevent right-sided heart failure and arrhythmias in later life. So again, a patient if developing pulmonary hypertension, although rare in ASDs to develop early, but sometimes it does, you have to rush to closure of the ASD. Right-sided overload or uncontrolled heart failure are all indications of intervention. This is a device closure of an secundum ASD. As here you see, that's a device that is used to close the atrial septal defect by catheter. So kindly be ready with your questions in the next face-to-face session. And for further readings in pediatric cardiology, these are the references for it. And listen to murmurs on the following sites, and we're going to listen again to murmurs together. Good luck. Thank you.